Welcome back. Here is a patient who comes in with a chief complaint of, quote, I have a sore on my foot. We have a 64-year-old man presenting to the ED complaining of worsening foot pain over the last several days. He noticed a sore on his left foot a couple weeks ago, but said that it did not hurt, so he placed a bandage on it. Since then, the sore has gotten larger and it has begun to hurt. He rates the pain as a +5 out of 10 and describes it as aching in quality. It does not radiate. Patient has a long-standing history of hypertension and type 2 diabetes. His most recent A1C was 9.1%. Medications include lisinopril and metformin. Vitals show a blood pressure of 140/95, heart rate 100, respirations 13, temperature 99.1, saturation 99%. Physical exam is remarkable for a 2 centimeter diametric circular ulcer overlying the first metatarsal head of the left foot, exposing bone and foul-smelling white discharge. There is surrounding erythema and swelling, and it is exquisitely tender to palpation. Pedal pulses are diminished bilaterally. The skin of the leg and foot is smooth and lacks hair, and we're going to say that's bilaterally as well. The remainder of the physical exam is normal. So what is the most pressing thing that this guy has? Well, it's this ulcer, of course. So he's got an ulcer, and what kind of ulcer is this? What's this caused from? The underlying cause is his diabetes. Now, there are a couple things that diabetes causes that predisposes you to ulcer. And one of those things that's very important is peripheral neuropathy. Peripheral neuropathy is going to reduce your ability to sense pain. Now, it does other things. Peripheral neuropathy can cause those sort of paresthesias, pins and needle feelings, which can happen on their feet and on their hands. It can also reduce your sensation of pain or discomfort. So we call that hyposthesia, which is technically reduced touch sensation, but typically it's going to reduce their ability to feel anything, pain, light touch, etc. So there's peripheral neuropathy. What else do we see here? We see signs of peripheral artery disease. Diabetes will worsen that, but you can get peripheral artery disease in the absence of diabetes as well. So peripheral artery disease we note with the diminished pedal pulses as well as the skin changes. So with peripheral artery disease, you get changes to your skin because you have decreased circulation. So oftentimes you'll see this. You'll see a guy who has hairy arms, hairy chest, hairy belly. Then you look at his legs, the ends of his legs, and there's very little hair. The skin is shiny and thin. That's because of reduced circulation, and that is a sign of peripheral artery disease. So you put all these together, it's the peripheral neuropathy, the reduced detection of trauma and ongoing pressure, and then the peripheral artery disease, which reduces circulation. Put those two things together, and you have a recipe for a diabetic ulcer, and that is in fact what he has. Now, if you look at a diabetic ulcer, they're very, very, very nasty looking things, and I'll show you some pictures. But this guy's, you can actually see the bone, and that is very alarming when you see that. But note his pain. It's only a +5 out of 10. Now, if you press on it, it's going to hurt worse, obviously. But if I were to take a big wedge out of your foot and you all the way down to the bone, you would go through the roof, assuming you don't have diabetic neuropathy. But the fact is, he's got diabetic neuropathy that's reduced his ability to sense pain so significantly that even this big, ugly ulcer is not causing really severe pain. +5 out of 10, that's, uncomfortable, but it's not the worst pain he's ever had. And so those two things don't match up. And that is why these patients get ulcers. What it is it's a lack of an ability to detect discomfort. And normally when we sit down, so I'm kind of a thinner guy, and I go to sit down on a chair, like a wooden chair, and one of the things I'll notice if I've been sitting for half an hour, 40 minutes, is that my butt starts to hurt because it's a little bony. I need to, do a little bit more glute work at the gym maybe. But it's bony and it's uncomfortable. And so what do? Well, I shift positions in the chair or maybe get up for a little while. Well, these people with with peripheral neuropathy, they don't get that discomfort to move, and so they will have their feet in a certain position or have their back in a certain position where they're laying down, or they've got their feet in shoes, and they won't shift positions because they don't have discomfort, and that pressure ultimately will lead to the ulcer. So other places that you'll see ulcers in patients is anywhere where there can be pressure. So they can have it on their their sacrum. They can have it on their feet. They can have it on the sides of their legs. And that's why we turn patients in the hospital, especially patients who are bedbound, is that we don't want them to develop ulcers. And we see these with patients with peripheral neuropathy, diabetes, and the peripheral artery disease is just going to make that all the worse. And so, very important that you recognize that in patients with peripheral neuropathy, they need to have good foot care. Otherwise, these things will develop. So our assessment of this patient is very poorly controlled type 2 diabetes, that A1C was very high, along with a left foot ulcer, which is probably infected. So this foul-smelling white discharge is a strong indication of infection. Bilateral atherosclerosis of the lower extremities, that's the decreased pedal pulses, and then diabetic peripheral neuropathy. So our differential here, what is this ulcer? Why does he have it? Well, it's either just a superficial foot ulcer, I guess you wouldn't say superficial, it's a foot ulcer which exposes bone without osteomyelitis, or he may have osteomyelitis. That is the thing that we are worried about anytime you have a patient with an ulcer that's exposing bone, you're worried about osteomyelitis. Because an ulcer itself can be treated with wound care. Okay, and eventually that ulcer should close up. You have a good wound doctor making sure that they look at that sore. They're going to, sometimes they'll be putting things in it. The wound care docs are really good with that. That's not my area of expertise, but those ulcers can be treated with wound care. However, if it's osteomyelitis, the patient's going to need antibiotics. If it's osteomyelitis, the bone is infected. Okay, an ulcer itself is not necessarily infected. But osteomyelitis, you have infection and you're going to need antibiotics. So that is where we need to make our differential here. Does he have osteomyelitis? We don't know. Okay, patients with osteomyelitis, especially if it comes, as we're going to see, if it comes from diabetes, they don't necessarily have a fever, they don't necessarily have a white count, and so it's hard to know. You're going to need to do further testing. Okay, so what do? Here's our initial workup. Okay, I should have asked you first, what do you think we should do? Well, here's what we're going to do. We're going to get a CBC and culture. CBC, yeah, it's good. If you do have an elevated white count, that really points to infection, but with diabetic ulcers and associated osteomyelitis, you may not have an elevated white count. The absence of it does not preclude osteomyelitis. But what's important here is that we're going to get a blood culture. In some cases, in any case of osteomyelitis, if you're suspecting it, you should always get a blood culture, because if the blood culture comes back positive, you probably know what your causative organism is. However, again here, with diabetic ulcers that lead to osteomyelitis, because it's not necessarily affecting the blood, you are probably not going to culture anything out here. Now, there are some causes, the more common causes of osteomyelitis, hematogenous osteomyelitis, where you get an infection in the blood and it seeds the bone. In that case, you would have a positive culture. We're going to talk about hematogenous osteomyelitis in a little bit. So you'll get a CBC and culture. A SED rate is good. I don't like to get SED rates, and I don't like to get CRPs, because they're very nonspecific. However, a SED rate does have a little bit of use in osteomyelitis, because you're going to take that SED rate and you're going to compare it every day to monitor the response to treatment. So it can help to get a baseline SED rate, but that's not going to tell you whether or not the patient has osteomyelitis. Okay, the fact that there is an infection going on or any kind of inflammation can raise the SED rate. There's so many different things that can do that. But a SED rate in the setting of osteomyelitis, when you do treatment, you're going to be getting a SED rate to monitor the response to treatment. So that's why I included it here. And then you want to get an x-ray. So you may have been thinking, osteomyelitis, I need to get a bone scan. No, I want you to dissociate those two things. Osteomyelitis and bone scan, dissociate those two things, please. Because a bone scan is not going to be the correct answer on a medical licensing exam. Bone scans are not very sensitive, they're not very specific, and so they're not very good tests to get for osteomyelitis if you're suspecting osteomyelitis. Only 25% specific. So there is one circumstance where a bone scan may be a good idea, and I'll tell you what that is in a little bit here. But the best first test to get when you suspect osteomyelitis is a plain radiograph. And it takes a couple weeks from the onset of symptoms to have signs on an x-ray. But it doesn't mean that you don't get that as the first step, because it's an easy, cheap thing to do, and if it comes back positive, it's very good to indicate osteomyelitis. So you're going to get that even though you know in the back of your mind you may need to do something else. Okay, so CBC with culture, SED rate, x-ray of the left foot. And what do we find? We find with our CBC we have a hemoglobin of 14.1, hematocrit 42.8, white count 9.9, platelets 320, MCV of 88. So what do we make of this CBC? Absolutely nothing. This is a normal CBC. What about culture? Well, your culture is going to take a few days to come back, so that's pending. SED rate, 98. Very high. Very high. Often with osteomyelitis, you're going to see SED rates 80s, 90s, and above. So this is very high. Okay, what about that x-ray? So here it is. Where did we say his lesion was? His ulcer was the head of the first metatarsal, so that's right here. And what do we see? So the classic sign that you're going to see with osteomyelitis, but you're not always going to see it, but the classic sign to see with osteomyelitis on x-ray is what's known as periosteal elevation. Now we don't really see a whole lot of that here, but what we do see is changes of the bone. So we see some inflammation and bone deposition here. So on the plain film, when you get it on a patient with osteomyelitis, remember it takes a couple weeks from the onset of symptoms for them to actually develop signs. But what you will see eventually is erosion of the bone, some alteration of the bone, which you see here, and then periosteal elevation. The periosteal elevation is a little bit easier to see when it's long bones, like the tibia, fibula, femur, if it's affected. Not as easy to see in these smaller bones, but if you look really closely, this is not the best view, you do see changes to the bone though. Okay, so this is consistent with osteomyelitis. Note that there aren't any fractures here though. Okay. So periosteal elevation of the left first metatarsal head. That was the write-up that I saw with this particular X-ray. I'm not a radiologist by any means. Okay, so periosteal elevation of left first metatarsal head with surrounding new bone formation, and that is consistent with osteomyelitis. Now note that I say consistent. It's not diagnostic, but it's consistent. We're going to still need to do more things. And what are we going to do? A bone biopsy and culture. Absolutely mandatory to get a bone biopsy and culture, provided that you don't have a positive blood culture. And with diabetic ulcers leading to osteomyelitis, you're typically not going to have a positive blood culture. So if you have a picture consistent with osteomyelitis, you get your x-ray, it looks like osteomyelitis, your next step is to get a bone biopsy and culture. And the reason we get that is not only to make a definitive diagnosis of osteomyelitis, but also to understand what the causative organism is, because that is going to dictate how we treat the patient with what antibiotics. Okay, the question now, once you get a biopsy, it's consistent with osteomyelitis. The question is not do we treat, it's how we treat. And there's a whole array of antibiotics. We need to pick the right one. Okay, so we get the bone biopsy and culture. The biopsy reveals abundant neutrophils. The culture is pending. Culture will take a few days to come back. But the biopsy is very indicative of osteomyelitis. And so we are going to treat this patient at this point. But I have it on pretty good authority that, and you will see disagreement in the literature, but I have it on pretty good authority that you do not need to treat right away. People don't die from osteomyelitis. They may die from infections of the skin, but they don't die from osteomyelitis. Now, certainly you're going to treat his wound, but you don't need to throw antibiotics at him right away. You can wait for the culture to come back. All right, so, but that's why it's important to get the culture, because you want to know what the causative organism is of his osteomyelitis. So diabetes is the #1 risk factor for osteomyelitis in adults. 15% of diabetes patients will go on to develop a foot ulcer at some point in their life, and 1/4 of those patients will require an amputation. So if you do the math, 3% of diabetes patients will have an amputation at some point in their life. That's quite a few. Most cases of osteomyelitis result from contiguous spread or from open wounds. The #1 cause is Staph aureus. However, gram-negative rods are not uncommon. So a few different, actually, I have here some pictures for you. Okay, so remember what I said, pressure points are where ulcers tend to develop, and that holds for diabetic patients who tend to get ulcers in their foot. So really anywhere where you have pressure points, you can get an ulcer. Now, a patient who's just laying on a bed, where do you think their ulcers are going to be? They're going to be in the back here, like on the heel. This would be a patient who's walking around, who's got shoes on, but you have to just consider where's the pressure. Okay, so this would be where you would typically expect to see the pressure points. So one way to think of it, if you are a little bit older, maybe in your 30s or 40s, you look at your foot, you see that you've got a little bit thicker skin on your foot, called callus. That is in pressure-bearing areas because your body responds to any time you have a lot of pressure on your foot. If you do a lot of walking, your skin will thicken, and that's where you put pressure on your foot. So if you look at your own foot, you may note some calluses, and that's totally normal. But those are the pressure areas. Okay, so these are where the ulcers will tend to develop in a patient with diabetes. So here is a good example. On the medial surface of the great toe, you see an ulcer. And again, here you see this is a nice clean ulcer. You just see some granulation tissue here. But this is what we expect an ulcer to look like that's not infected. Okay, now, alternatively, you may see an ulcer with some surrounding inflammation and infection. So this could be some cellulitis here with an ulcer, associated with an ulcer. This looks infected to me. Now, one of the things that you'll see with peripheral artery disease is thickening of the skin. So that is, thickening of the nails. So that is something that you want to pay attention to when you're looking at any patient's feet, especially with diabetes. Anytime a patient comes in for checkup who has diabetes, you want to take a look at their feet. Okay, so this is characteristic of not only an ulcer, but also the peripheral artery disease as well. Okay, so this is one of the ways that we actually can treat ulcers. If there's any kind of infectious tissue, or if there's eschar, dead tissue, you can actually use maggots. And maggots will eat dead tissue, but they won't eat live tissue. And so you put these maggots in the ulcer, and they actually will clean it up quite nicely. A lot of patients, this will make them just totally nauseous if they look at it, so we don't use this as much. But I worked with a wound care doctor a few years ago, and he actually uses maggots. So it's old treatment, but it actually does do the trick. There's lots of different wound care products out there, though, different meshes that they can put in there, and so forth. So I showed this to my grandma, my 91-year-old grandma, and she about lost her cookies. So the causes of osteomyelitis, there are three classifications, I suppose you could say. So the first one is hematogenous osteomyelitis. And hematogenous osteomyelitis is exactly what it sounds like. It results from having bacteria in the blood, which then goes on and seeds the bone. And typically this is going to involve the vertebrae. So the kinds of people that develop hematogenous osteomyelitis are particularly IV drug abusers, also patients with sickle cell disease. Remember, sickle cell disease, 10 times increased risk of salmonella. And then the elderly. And when we're talking about the elderly, we're talking especially about patients who are sick, hospitalized, who have indwelling urinary catheters, IV catheters. Patients who have diabetes have an increased risk of hematogenous osteomyelitis. But this is not resulting from any kind of wound or concurrent infection. This is from having bacteria in the blood, which then seeds a bone, and usually it's going to be vertebrae. These patients, because they have bacteremia, they're often going to be very sick in presentation, so they'll have a sudden onset of severe constitutional symptoms, fever, chills, night sweats, etc., and then some pain and tenderness of the affected bone. Like I said, it has a tendency to develop in the vertebrae. It can also affect the surrounding disc and also other surrounding vertebrae. This can go so far as to actually form an epidural abscess, and when you get an epidural abscess, it can cause compression on the cord, and that can lead to motor and sensory loss, so you want to pay attention to that as well. So usually it's the vertebrae, but occasionally it can affect the long bone, and when you have long bone osteomyelitis from a hematogenous spread, we actually call that a Brodie's abscess, but that's pretty rare. Okay, this second classification is osteomyelitis without vascular insufficiency from contiguous spread. So typically this results from having prosthetic joint placement. And when you have a prosthetic joint that's being placed, you can get infection from that, from the surgery. So this is like an iatrogenic cause of osteomyelitis. Another way that you can get osteomyelitis without vascular insufficiency via contiguous spread is, let's say that you step on a nail or something like that, and it introduces and inoculates bacteria into the surrounding tissue of the bone, which can then affect the bone itself. So this can be due to trauma. But most commonly, this is due to surgery. So surgery or trauma. And then what we have in our patient's case, osteomyelitis with vascular insufficiency, often resulting from an ulcer or a lesion. And so this is typically in very unimpressive presentation, as we saw in our patient, very little pain, usually owing to diabetic neuropathy. The most common site for osteomyelitis to present is in children, the long bones, the tibia and femur, and in adults, the vertebral bodies. Other places you see it in adults are other long bones. You can see it in the pelvis, you can see it in the clavicle, but especially when we're talking about diabetic patients, the foot, because of the peripheral artery disease, the peripheral neuropathy, the pressure on the foot, leading to ulcers and subsequently osteomyelitis. The symptoms include pain at the affected site, which can be variable. With hematogenous osteomyelitis, the pain is typically quite severe. With patients who have diabetes and peripheral neuropathy, their pain is going to be abbreviated. They may have cardinal signs of inflammation, fever, rubor, calor, dolor. There may be purulent drainage if it's associated with a wound. All right. So for diagnosis, when you suspect osteomyelitis, the best initial test is a plain radiograph of the affected bone. If that comes back negative, then you get an MRI. Okay, an MRI is much more sensitive, and usually it only takes a few days from the onset of symptoms for an MRI to come back positive, whereas it takes a couple weeks for your x-ray to come back positive. So if you suspect osteomyelitis, your first step is to get a plain radiograph. If that comes back negative, and oftentimes it will, then you get an MRI. Once one of those are positive, though, then you go and you get your biopsy. The bone biopsy and culture is the gold standard and should be done anytime you have radiographically confirmed osteomyelitis. The only time you can really skip the bone biopsy and culture is when you have a patient who has suspected osteomyelitis and a positive blood culture, because in that case it's likely hematogenous osteomyelitis and we've already grown the causative organism from the blood culture. So in that case you may be able to skip it, but that's a judgment call from the ID doctor. I wouldn't make that call personally. Like I said, lab tests are non-specific, but blood cultures should be obtained, especially if hematogenous etiology is suspected. That SED rate, it's not very specific, but it's good because you'll use it to follow up. What are things that aren't so useful? Bone scan. So bone scan is the most common wrong answer for working up osteomyelitis. The only time you're going to get a bone scan is when you want to do an MRI in somebody, but there's contraindications. So, for instance, they have a pacemaker. You can't do an MRI in a patient with a pacemaker, of course. So, in that case, you can get a bone scan. But we try to avoid bone scans. And then culture of the discharge. Again, wrong answer. What happens if you get a culture of the discharge? What do you think you're going to grow? You're going to grow skin flora. And that's probably not what's causing the osteomyelitis. So you probably grow Staph aureus, and Staph aureus is the most common pathogen. But it's not going to tell you what's causing the osteomyelitis. Okay? So we don't get a culture of the discharge. Bad idea. You do want to get a bone biopsy and culture, though. So the most common pathogen is Staph aureus. You should know this. Staph aureus is the most common pathogen. What else do we see? Occasionally you'll see strep. Occasionally you'll see gram-negatives, things like salmonella. Occasionally you'll see pseudomonas, but Staph aureus, the number one cause of osteomyelitis. All right, so do not answer bone scan. Do not answer culture of discharge. You want to get first an x-ray. If that's negative, get an MRI. If that's positive, go on and get your bone biopsy and culture. MRI, if that's positive, go on and get your bone biopsy and culture. So what do we do to manage these patients? They need to be admitted. Why do they need to be admitted? Because they need to be on parenteral antibiotics. 4 to 8 weeks of parenteral antibiotics. Now, in practice, you will probably have these patients on parenteral antibiotics for some time and then transition them to oral antibiotics. And so you can discharge them, and you don't need to keep them in the hospital for so long. And there is some evidence in the literature saying that you can just put them on oral antibiotics from the beginning, and you don't even need to have them on IV antibiotics at all. That is not very well established yet. And so for test-related purposes, the answer is going to be admission with IV antibiotics. Now, as I said before, you don't need to come at these patients right away and throw empiric antibiotics at them. Okay, I have it on pretty good authority that is not necessary. You can wait for everything to come back and have them under observation without antibiotics and then put them on antibiotics after your cultures and sensitivities come back. However, on the test, if you're given a vignette and the patient has osteomyelitis and they're asking you what antibiotics do we give and they don't tell you what the causative organism is, then I would recommend one of two things. Either do one of those extended spectrum penicillin beta-lactamase combos like Zosyn, piperacillin, tazobactam, or you can do a quinolone. Quinolone like ciprofloxacin. And you may add to the quinolone, you may add rifampin. Some doctors do that, but one of these two would be good. Now note that neither of these cover MRSA, so you may add vancomycin to this to cover MRSA. But, as I said, it's generally pretty common practice to wait for the causative organism to be identified, what that's susceptible to, and then give that antibiotic, an appropriate antibiotic for the particular causative organism. But on the test, like I said, if you get asked and you're not told what the causative organism is, I would choose one of these two things and then maybe add on something like vancomycin to cover MRSA as well. Okay, so those are your options. As I said, you want to, at some point, tailor the antibiotics to the culture sensitivities when you have those. You'll monitor the patient's response with serial ESRs, and that SED rate should start to come down. As far as consultations, you want to consult general surgery for debridement. Some of these patients may need amputation. So you'll want to have them on board, at least come in and take a look at the patient and determine whether or not the affected digit or the affected limb, foot, whatever, is salvageable. And they'll be able to do any kind of debridement, because really debridement is going to be useful in addition to your antibiotics, because if you have dead tissue, that tissue is not going to be repaired with antibiotics, so you need to get rid of that tissue. Okay, so surgery will be good for that. So at least consult them. And then these patients will follow up with a wound care specialist. Okay, so antibiotics, that's the treatment for osteomyelitis. They're typically going to be given parenterally, and generally you will wait to give the antibiotics until the culture sensitivities come back, at which point you can choose an appropriate antibiotic. However, if you are asked on the test what to do and you're not told the causative organism, then you'll want to go broad spectrum and either do one of these combos like piperacillin tazobactam or do a quinolone. And you can add on something to cover MRSA if you feel so inclined. And that is all I have for you. Hopefully you learned something from this. If you have any questions, go ahead and write me a message through Patreon or under the comment section of the video.